flow time and voiding time, particularly definitions. When we look at the definitions of these terms, you'll be aware that the time over which measurable flow actually occurs is the definition of flow time. The problem with that is that when on a urodynamics machine you're measuring zero flow, your machine has a little bit of noise due to digitization and electronic noise, so it's never exactly zero. That means measurable flow does not mean zero flow in your urodynamic machine. It's a problem. The problem with the definition of voiding time is total duration of micturition, is that in most voids you have a few drops afterwards. Do you count those or not in your voiding time? And especially in urodynamics, you ask your patient to cough at the end, which is an artificial cough, and they might leak some more. Do you count that in voiding time or not? And in terms of the definition of underactivity, you'll recall that it includes the phrase normal time span, but we don't know what normal is. So we're out to answer these questions as part of this study. We've published before on our urodynamic database of about 28,000 patients, but from very carefully defined groups, we also looked at this number of flow time and voiding time data, split up into different diagnoses. And we found that there are significant differences between the flow time and the voiding time, between normal patients and between patients who either have obstruction or underactivity or a combination. Put graphically, you can see that the normal patients have a lower flow time. These results are matched for age. In voiding time, it is even greater. So you're taking into account the delays between different elements of the flow, and you see that the normal patients are significantly lower in their voiding times. And this would suggest that the definition of normal time would be 60 seconds. Of course, these patients are not normal because they've been given urodynamics, but they have other symptoms than would be indicated by underactivity or obstruction. What gets more interesting is when you look at the average flow, firstly measured over flow time, the time when flow is occurring, but also when measured over voiding time. The flow time difference for average flow is significantly greater for normal patients than for underactive or obstructed patients. This is even more the case when the average flow during voiding time is taken into account, because down here you can see the difference between the underactive patient and the obstructed patient is significant. We could possibly here have a differentiator between the obstructed and the underactive man, which is to some extent the holy grail of urodynamics. If the average flow during voiding time is less than 6 mils per second, it indicates dysfunction of some sort. The really exciting thing about that is that anyone can measure it with a stopwatch and a bucket, because it only depends on total volume and overall time. No flow meter required. So in conclusion, we'd suggest that the normal time span for voiding can be less than 60 seconds, that we should agree a threshold for measurable flow. Most machines would call that 0.5 mils per second, and that post-void leaks due to coughing or movement should be discounted when you're considering voiding time, and that the average flow rate over voiding time is a good screening. In simple terms, with very simple tools, the normal value would be greater than 6 mils per second, and when you correct the results for age, you could possibly diagnose between DU and BOO in the male. Thank you very much.
Thank you, Dr. Gammie. Open for question, please.
Hi, Arnold. Peter is here from Utrecht, Netherlands. I completely agree with your observations and happy to see them. You go back, I think, 3 decennia where we had a discussion about maximum and average flow rate being the one or the other the best predictor for bladder outlet obstruction in men. So you extended to detrusor over underactivity, which was not in vogue at that time, and women. Do you suggest that average flow rate is over the whole better predictor of abnormality versus, in your words, normal patients, or is in any way maximum flow better predictor in some circumstances?
Thank you. Well, maximum flow obviously has been the main indicator for decades. The difficulty in our study was that the maximum flow rate was one of the categories that we used to split the patients into groups. So we found it hard to use that statistically as an indicator. However, what I said, I think is probably the most interesting feature for future diagnostics is that the average flow is easy to measure because you don't need a flow meter.
Sure.
So stopwatch jug, primary care, we may well have a good screening tool here.
Was known, and there have been trials in primary care, especially with that in the late 80s.
But then when you correct for age to diagnose between DU and BOO without having to put a catheter in, I'm very interested.
So that was my next question, if you allow. That is that you might be disappointed that it doesn't separate between the detrusor underactivity, the average flow, and bladder outlet obstruction, or did you expect that?
There is overlap, but when you correct for age, and our current interest is to combine it in multivariate analysis with symptoms, with straining, and so on, you may well have a much more sensitive indicator than we've had so far. So the results look promising, we feel.
I mean, in your data, your standard deviation is quite big. So you can identify underactive bladder and obstruction?
Yeah, we were actually using interquartile ranges rather than standard deviation, but the overlap is large, you're right. What I couldn't show on the slides is how the age-matched statistical figures actually strengthen the differentiation between the two groups. The figures overlap, but when you correct for age, there is a better separation between the groups.
Okay, we need to move on. Thank you very much.
Okay.